Top-Bed Talk.
We're now going to hear about the highs and lows of implementing enhanced recovery after surgery. Very pleased to welcome Professor Tim Miller, who's an anesthesiologist at Duke University Hospitals in North Carolina, US. He's a Brit that's gone abroad. He's got a long history of implementing ERAS, led the implementation of ERAS at Duke, and has served as past president of the American Society for Enhanced Recovery, as well as having this as one of his many research interests. So very pleased to welcome Tim this morning.
Morning, everyone. Pleasure to be here again, back at EBPOM. And thank you to the organisers for the invite and to this slightly cryptic talk title. I decided how I would take this is really high level, go over the history of enhanced recovery, because I think it's relevant about the implementation cycle from the initial evidence through some of the consensus statements, professional organisations and actual real world implementation. And highlight some international differences. It's been very different from country to country, how it's been implemented. I know a little bit about the NHS. I know about the challenges in the US. I've been involved a lot nationally and with ASA, particularly the American Society for Enhanced Recovery, talking about implementation of ERAS. So as you know, this all started a while ago. This was one of the first papers by Henrik Kellett back in 1997, theorizing that all patients get this dip in function after major surgery. And if you do multimodal interventions, you can reduce this dip in function and your patients can go home earlier and happier. Henrik's landmark paper was in 1999. Planned discharge after 2 days for patients having major open sigmoidectomy. It was revolutionary. Henrik was a revolutionary surgeon. He really changed practice. At the time, the average length of stay was 7 to 10, maybe 14 days for open colorectal surgery. And interesting, his pathway was in many ways fairly simple. It was analgesia, an intrathecal catheter to get a level of T4, not placed at T4, with a GA, epidural for 48 hours, and then fairly quickly after that, planned discharge. And the big change was immediate mobilization and nutrition. So living the dream. That was something that wasn't done before. Even when I was training, I remember the patients lay in bed for several days. They weren't fed until they had bowel sounds. Then they got SIPs. And it was thought to be dangerous. And Henrik broke down these barriers and had immediate mobilization and nutrition. It probably was a little bit too soon. They had a 25% readmission rate. This study was actually only 16 patients, but he broke down those barriers and showed that this was possible. Following Henrik's early work, the ERAS study group was formed. This was initially 5 members, surgeons, mainly from Scandinavia. And in 2005, 6 years after Henrik's work, there had been some small studies, mainly before and after type studies. They looked at the literature, but essentially did a document which was mainly expert opinion. And this document had this well-known wagon wheel of enhanced recovery. You see, this group had really expanded Henrik's ideas to make it a lot more thorough, but also more complex. They'd added in things such as the carbohydrates drink, and many of these things that you see that have become integral to enhanced recovery pathways, some successes, but also some difficulties in complex intervention. And the evidence base continued to develop, moving on from more observational studies to randomized controlled trials. You can see in 2010, there were 6 randomized controlled trials, nearly 450 patients, consistent reduction in length of stay. And we've seen that in enhanced recovery. And if you do the early feeding and mobilization, you will get a consistent reduction in length of stay and no compromise in patient safety. If you look at the elements at the top here, you can see the preoperative and intraoperative elements that set you up for that are a little bit variable between the studies. If you look at the postoperative elements, all those patients are eating, mobilizing, drinking early and getting those improved outcomes. Around the same time, April 2009, the NHS Partnership Programme for Enhanced Recovery started their implementation of enhanced recovery. And I think you've got to give a lot of credit to the NHS. In the UK, at least from overseas, someone who's been in the States since 2007, the NHS does enable you to have that overarching framework where you can implement at a national level. We can't do that in the US. We have no organisation that plays this role to be able to implement at a national level. So it really is one hospital against another, and each hospital has to do its own implementation. We're really competitive with other hospitals. Whereas the NHS, and we saw a bit of this with Peak yesterday, is able to implement national programs. And you can see here in this summary, they went over the evidence. It enables earlier recovery, quicker discharge from hospital. The intervention's been successfully implemented, replicated, linked to standards and guidance, supported by national organisations. There's an evaluation of the evidence that's been carried out, and there are publications. So a very thorough review suggesting implementation of enhanced recovery. And along with this was an implementation guide at a national level. And correct me if I'm wrong, but I don't think this has been done at a national level in any other country. And finally, also look at compliance with implementation. And this is very important. This is just a year after the implementation. In the UK, you're able to get compliance at a lot of these different elements of enhanced recovery. It was only around this time the ERAS Society, the International Society, was formed from the ERAS study group in 2010, which just shows how an early adopter of enhanced recovery the UK was. And the ERAS study group put out this paper on adherence to outcomes, looking at the different elements of the pathway, showing clear relationship between symptoms, morbidity, readmissions, length of stay with adherence to pathway, really trying to push people to get those greater than 90% adherence to different elements of the enhanced recovery pathway. A few years later, we got on board in the States, and I was involved with TJ Gann and others in 2014 in forming ACER. This is sort of the peak of interest in enhanced recovery in terms of the first international meetings. Again, 13 years after Henrik's initial publication with the first World Congress. Myself and others in this room, Mike Grocott, were involved in 2015 in a joint meeting between the ERAS Society, ACER and EBPOM. And you can see that was in Washington, D.C. with delegates from many countries all over the world. ACER took a slightly different approach to the ERAS Society. We partnered with POCI to do some consensus statements. POCI you'll hear more about today, the Perioperative Quality Initiative. These consensus statements were getting a group of experts together and trying to delve into different aspects of the enhanced recovery. One of the problems with enhanced recovery is it's such a complex intervention with many different elements. We wanted to look at particular elements: fluid management, analgesia, preventing infection, and importantly, measurement and quality. How do you measure and feedback outcomes to increase compliance and adherence to enhanced recovery pathways? We published a series of papers in perioperative medicine. We also did an implementation guide. We mirrored what the NHS had done, but in the States, we had to do it through a society. So we did it through ACER because we don't have something like the NHS. We also did a series of implementation forums. I led those with Julie Thacker, and we would invite individual hospitals to come for a 2-day workshop. They would come with a surgeon, an anaesthesia provider, a nurse, and the manager. There would be 3 or 4 hospitals, and we would sit in the room with the hospitals for the weekend and really go through everything about enhanced recovery, so they would leave with a plan for implementation at their hospital in their local environment. And that was probably the most successful way that we helped hospitals to implement enhanced recovery, at least in the US. And this is the basic plan that we came up with for suggesting that hospitals implement. You assemble your team, surgeon, anesthesiologist, etc. You look at all the evidence. Importantly, you interpret the evidence in light of your local experiences, surgeons, resources, patient population. You write your protocol, you implement your plan, and vitally important that you measure outcomes and feed them back to the team. Because a lot of these team members are going to be doing extra work implementing enhanced recovery, and if they don't see feedback of their successes, failures, what works, what doesn't, it's very hard for them to stay enthusiastic and revise the protocol in light of these outcomes. And again, in the US, similarly, looked at adherence to elements of the protocol with outcomes and very similar results. Interestingly, when you look at the components of the protocol that were analysed here, and this was through NSQIP, which is similar to PQIP, but in the US, the National Surgeons Quality Improvement Project, they very much looked at preoperative and intraoperatively, multimodal analgesia, PONV, counselling, and then those dreaming elements postoperatively. If you can improve that, you improve adherence, improve outcomes. So where are we now? Enhanced recovery has been around for 15 years now. This is the most recent meta-analysis, and now 74 randomized controlled trials, 9,000 patients, consist a reduction in length of stay and complications without an increase in readmissions. The evidence is there. Enhanced recovery, it varies from hospital to hospital. It's a complex intervention. There's no set definition of what it is, but as a general rule, it works. But what about the actual implementation? We heard yesterday from Ramani in the UK that enhanced recovery has got to largely evolve to sort of the dreaming part of things, and in some way that makes a lot of sense. This is the most recent data from the US. This was a survey sent out to ASA members. So by definition, people who are interested in enhanced recovery have come to conferences and have joined an national organization for enhanced recovery. We got responses from 88 institutions. You see, the majority of institutions had a pathway in colorectal surgery. Again, don't know exactly what that pathway is, but they had that pathway. But when you drop down to other types of surgeries, implementation is still poor, no greater than 50% in any other type of surgery amongst people who are interested enough to join a national society, which I'm sure is higher than the overall implementation throughout the US. So it's still poor implementation generally. Institutions with a higher number of operating rooms, so the larger institutions, and also had a residency and an anesthesia and surgery residency, were more likely to implement. Because you have a lot of hospitals in the US which are small private hospitals with no residents, smaller number of ORs, that are less likely to implement enhanced recovery pathways. Interestingly, although a lot of these places said they didn't have enhanced recovery, I bet you if you ask them how many of their patients leave the with a nasogastric tube and don't get fed and mobilized for several days, I bet it's not many. So even though they don't have enhanced recovery pathways, I think a lot of times Henrik's dramatic change in practice has stuck, even sometimes if it's not labeled as enhanced recovery. This is a publication from this year from France, which is even lower. It's another survey. Only 20% of respondents reported using enhanced recovery. They said in general it's seldom practiced in France due to the unfavorable environment, logistics, funding, etc. And I think we would find similar statistics around the world. So why is implementation adherence suboptimal? Well, there is that knowing doing gap we've already talked about. So it takes a long time for things to get into clinical practice. I think with enhanced recovery, it's more the provider, organizational and institutional barriers. This large number of elements that went up from Henrik's initial work with 5 elements, getting up to 20 is often seen as daunting. And Henrik wrote a recent editorial in JAMA highlighting this point. And not just the number of elements, but the number of added things that have gone into enhanced recovery, gabapentinoids, IV lidocaine, different opioids, different analgesics, kept expanding over the years without necessarily the evidence base. So what are the barriers potentially to implementation of this complex intervention? Well, provider identified barriers, lack of agreement with the evidence, of course. There's always a reluctance to adapt to changes in practice. Resistance to a cookbook approach is a common thing, and we discussed that a little bit yesterday, that I don't think individualized patient care and a pathway are at odds with each other. You can have that platform, you can have that pathway and still individualize care on top of that. And then you can talk about your patient population. My patients are too sick. Low health literacy is a concern everywhere. We really do want to engage patients in their own recovery with enhanced recovery pathways. And of course, time limitations. Organizational barriers, coordinating across multiple departments, the need for education, particularly if you have rotating residents, you have a lot of turnover with staff. It's a lot of work doing all that education needed for enhanced recovery pathways. And then institutional barriers, which, as you may guess, are leadership, funding, and data collection. I think lack of good data collection is key. As I said, you really need to audit and feedback data if you're going to implement any new pathway in a hospital. And that is something that historically we have not been good at doing. This is one study from a few years ago looking at the relationship between length of stay and protocol adherence. They had a dip in their protocol adherence, and then the re-implementation cycle was dramatically improved things. And what they did is have a dedicated nurse practitioner. I think if you're going to do any complex intervention, having someone who is responsible for it and can do the teaching and spend the time spreading the enthusiasm is absolutely key. They also try to have trained nurse practitioners at all stages of care. Standardizing care is a theme. Specific ward, dedicated anesthesiologists or anesthesia providers. You have the same staff who know the pathway and who can spread the enthusiasm. And of course, auditing and disseminating those results. I think there is a huge potential for electronic healthcare records to help us do this. We get dashboards and continuous feedback for any protocol or pathway implementation. To summarize, enhanced recovery is a complicated intervention focusing on implementation and protocol adherence is complicated. And I look forward to the discussion. Thank you very much.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.